Welcome back to another explainer. Today we're doing a deep dive into the clinical presentations and diagnostic criteria of dissociative disorders. We are jumping right into the structural analysis of these psychiatric conditions to examine exactly how the human mind fragments to survive. Let's get started. Right out of the gate, consider this striking epidemiological stratification, 46%. Now, the lifetime prevalence of dissociative disorders in the general population sits at roughly 10%, which is already significant. But it absolutely skyrockets to 46% within psychiatric inpatient populations. That massive leap indicates a profound level of clinical severity and psychiatric comorbidity that we really need to unpack. But before exploring the specific disorders, we have to lock down the strict clinical definition of dissociation. Fundamentally, it's an unconscious defense mechanism. It involves the active segregation of mental or behavioral processes, things like memory, awareness, identity, or perception, splitting them off from a person's normal psychic activity. The mind is literally partitioning itself.
So, here is our clinical roadmap for this explainer. First, defining dissociation and epidemiology. Second, dissociative amnesia and fugue. Third, depersonalization versus derealization. Fourth, dissociative identity disorder. And finally, clinical distinctions and etiology.
Starting right off with Section 1, Defining Dissociation and Epidemiology.
Re-examining those epidemiological figures, the drastic stratification we just talked about becomes crystal clear. A 10% lifetime prevalence in the general public is definitely notable, but that massive jump to nearly half of all psychiatric inpatients? That highlights just how frequently these unconscious defense mechanisms escalate to the point of requiring intensive, inpatient medical intervention.
Moving into Section 2, dissociative amnesia and fugue.
When we meticulously detail the clinical presentation of dissociative amnesia, it becomes obvious that we're talking about something far beyond ordinary forgetfulness. The clinical hallmark is a stark inability to recall important personal information that's directly tied to a significant trauma or stressor. Practitioners actually have to watch for two distinct presentations here. You have the classical presentation, which is an overt, florid, dramatic disturbance, but then you also have the less apparent signs, like negative symptoms and cognitive deficits. And this amnesia rarely walks alone. It frequently brings along a host of associated features: broad alterations in consciousness, trance states, spontaneous age regression, and sometimes even ongoing anterograde amnesia. Now, nested right within this category is a highly specific, psychologically profound manifestation known as dissociative fugue. This involves sudden, entirely unexpected travel away from home. During a fugue state, the patient is completely confused about their own identity, or in some cases, they might assume an entirely new one. It is a total geographical and psychological displacement, and it can last anywhere from a few minutes to several months. Let's look strictly at the academic threshold required for a formal diagnosis. According to the DSM-5, all of the following criteria must be met. First, that inability to recall important personal information, usually related to a significant trauma or stressor, must be far too extensive to be explained by ordinary forgetfulness. Second, this memory loss has to cause clinically significant functional impairment or distress. And third, the symptoms absolutely cannot be due to other specific causes. This means clinicians must rigorously rule out dissociative identity disorder, post-traumatic stress disorder, acute stress disorder, or neurocognitive disorders. Treating this level of complex amnesia demands a highly methodical clinical procedure. The protocol typically kicks off with phase-oriented treatment to establish basic safety and stabilization for the patient. That can then be followed by hypnosis, which helps access those segregated memories. And from a pharmacological standpoint, specific interventions are utilized. Doctors might conduct facilitated interviews using intravenous amlobarbital or diazepam. These IV drugs are specifically deployed for acute amnesias and conversion reactions because they temporarily lower the patient's psychological defenses, making it possible to retrieve that segregated data.
Let's move on to Section 3, depersonalization versus derealization.
The clinical difference between these two states is stark but incredibly important to grasp. In depersonalization, the detachment is entirely internal. The patient feels as if they're observing themselves from the outside, often accompanied by a distorted sense of time and perception. Derealization, conversely, is an external detachment. The patient feels utterly disconnected from their surroundings. But here is the absolutely crucial shared trait: intact reality testing. Even though they are experiencing this profound sense of unreality, the patient distinctly understands that these are only feelings, not a genuine psychotic break.
Reviewing the pharmacological options for depersonalization and derealization reveals kind of a mixed landscape. Agents like benzodiazepines, SSRIs, naltrexone, stimulants, and RTMS, which is repetitive transcranial magnetic stimulation utilizing targeted magnetic pulses, appear partially efficacious for some patients. However, academically speaking, we have to emphasize one massive point here. There is absolutely no empirical evidence for the efficacy of antipsychotics in treating these specific disorders.
That brings us to Section 4, Dissociative Identity Disorder. To formally diagnose DID, the DSM-5 demands some incredibly strict criteria. First, there must be a profound disruption of identity, characterized by two or more distinct personality states. This involves a marked discontinuation in the patient's sense of self and agency. Just look at the incredibly broad scope of alterations here. The fragmentation actually cascades through a person's behavior, alters their memory and cognition, and even impacts sensory motor functioning. Second, this disruption is accompanied by recurrent gaps in recalling everyday events, personal information, and traumatic events. Again, far beyond what could be considered ordinary forgetting.
Interestingly, the structured treatment protocol for DID mirrors the methodical approach we just saw used for amnesia. It starts with phase-oriented treatment to build stability, moves into the cautious use of hypnosis, and relies on the application of IV drugs like amobarbital or diazepam for facilitated interviews during those acute amnestic episodes. So the therapeutic architecture actually remains remarkably consistent across the severe spectrum of dissociation.
Finally, let's wrap up with Section 5, Clinical Distinctions and Etiology.
A major challenge in psychiatry is distinguishing genuine dissociative identity disorder from malingering, which is basically feigned illness. The clinical presentation is the absolute key differentiator here. Patients with genuine DID are usually highly confused, conflicted, incredibly ashamed, and deeply distressed by both their symptoms and their underlying trauma history. In stark contrast, patients who are malingering frequently show remarkably little dysphoria about their supposed condition. The genuine presence of deep psychological pain is what fundamentally validates the reality of the fragmentation. Before finalizing a diagnosis of any dissociative disorder, practitioners are absolutely required to rule out a strict list of differential diagnoses. These dissociative symptoms have to be rigorously distinguished from major depressive disorder, generalized anxiety disorder, post-traumatic stress disorder, and primary psychotic disorders. Because there's so much overlap in symptoms, like emotional numbing or memory gaps, untangling these conditions requires exact clinical precision.
So what is the ultimate driver of all this? We finally arrive at the etiological root of these disorders. Ultimately, dissociation is framed as a fundamental survival response. It is a mechanism the brain actively deploys to cope with overwhelming psychological trauma when physical escape is utterly impossible.
And breaking down this etiology by the timing of the trauma reveals some very distinct patterns. The vast majority of these disorders stem from childhood, specifically chronic abuse or a highly unpredictable, frightening home environment where the developing brain literally partitions itself just to survive. Less frequently, however, these disorders can form from trauma later in life. These later cases are usually entirely unrelated to childhood abuse, stemming instead from massive psychological shocks, such as the trauma of war or the sudden devastating death of a loved one.
Which leaves us with this incredible double-edged reality of psychiatric etiology to ponder. How does the mind's ultimate defense mechanism against trauma, the ability to literally segregate its own awareness and memories, simultaneously protect and fracture the human psyche? It's a mechanism of pure survival, but one that comes at the severe cost of a unified self. I really encourage you to think deeply about the clinical implications of that as you continue your studies. Thank you so much for joining me for this explainer, and keep learning.